Welcome to Online Anesthesia Video of the Week. Today topic is presented by Dr. R. Asheetha, MD Anaesthesia. She completed her undergraduate MBBS during 2007 to 2012 in Tirunelveli Medical College Hospital and postgraduate in MD Anaesthesiology during 2014 to 2017 in Tirunelveli Medical College Hospital. Then she has joined and worked as an assistant professor in Thoothukudi Medical College Hospital during 2018 to 2020. She is currently working as an assistant professor since 2020 in Institute of Anaesthesiology at Madurai Medical College Hospital. Her areas of interest are pain management, critical care, research-oriented anesthesia practice and anesthesia teaching.
Good morning, everyone. So I'm Asheetha from Madurai Medical College, consultant anesthesiologist. I'm here to discuss about the basic modes of ventilation. So let's go to the topic. Let me share my slides. Here is a simple comparison between the modes of ventilation and the car gears. So on the left-hand side, you see the car gears numbering from 1, 2, 3, 4, 5, and the reverse gear. So how does it correlate with your modes? When you start to drive a car, you start with a neutral mode, which can be compared to the control mode of ventilation. Here, you can only start the car. You cannot move further. That is the neutral gear. So next gear is your driving gear or the driving mode, first gear. So with this gear, you start moving with a little assistance. But this is not the mode where you can reach the destination. The same is compared to the assist control mode of the ventilation. And the next gears like second, third, fourth, fifth, and sixth are the higher gears, which will give a faster ride. This can be done only when the road conditions are good. The same here. This can be compared with your weaning modes. When the lung conditions are good, you can down-regulate your modes and you can extubate the patient. So next, coming to the destination. So you want to park the car or extubate the patient. For parking the car, not every parking needs a reverse gear. You can park straight away. But in certain conditions like hemodynamic instability or neurological dilemmas, you can continue to ventilate the patient, which can be compared to your reverse gear. So with this intro, let me get into the ventilator ride. Well, by definition, it's a tool that interacts between the patient and the ventilator. So it can be defined as a sequence of breath delivery, which is based on the relationship between the ventilator's phase variables and also the patient's respiratory patterns. This can also be a combination of these three. That is breath control variable, breath sequence, targeting scheme. So in breath control variable, you have volume control and the pressure control. Whereas in breath sequence, you can say whether it is a mandatory ventilation or a spontaneous ventilation, whether it is continuous or intermittent. In targeting schemes, this is mainly oriented towards the advanced modes of ventilation. You can have more types of targeting schemes like set point, adaptive, servo, intelligent, optimal, dual variable, bio. So all these depends upon the signals sensed by the ventilator and the response given by the ventilator, which is based on the closed loop system. So our conventional modes of ventilation mainly depends on the breath control variable and the breath sequence. So now this is a schematic representation of your ventilator. You have a blender. You have a blender, a control unit, an expiratory valve and the inspiratory valve, sensor. So any alterations in the flow, pressure or volume will be sensed by the sensor, and accordingly these valves will open or close, leading to the respiratory cycle. So here is the schematic representation. During inspiration, here the inspiratory valves open and the expiratory valves closed. During expiration, your expiratory valves open and the inspiratory valves close. But during your expiratory pause or inspiratory pause, both the valves get closed. That is depicted in this picture. So next, coming to the classification, your conventional modes can be further classified into control mode and the spontaneous mode. Control mode, as you know, pressure control and volume control. In spontaneous mode, you have pressure support. Added to it, you have CPAP and also P. Now, what are we going to discuss here in this class? That is, there is no mode which is called as universally accepted. Every mode is designed in a specific way that it suits the individual patient's criteria. So we have to customize the mode to the lung conditions, and you also have to alter the parameters accordingly. We are going to familiarize the ventilator languages like your phase variables, trigger, limit, cycle, mandatory breaths, all those things. And here we see the indications and contraindications of each mode, merits and demerits involved in each mode. And you have to set parameters for each patient according to the mode given. And also you have to synchronize the parameters to the patient's lung conditions. And also these are done only to encourage a ventilator-free period, that is ventilator independence. That will define the success of your ventilation. So phase variables, as you all know, trigger, limit, cycle. So what is a trigger? Anything that initiates inspiration is called the trigger. And what is the limit? Target which is achieved during inspiration is called as a limit. For example, in pressure limit, if the limit is pressure, then the pressure, if you set say 25 or 15, that limit has to be achieved by your volume. That is the idea of the limit. Next comes your cycle. Cycle is when the patient switches from inspiration to expiration. That is called as a cycle. So these are the definitions of your variables. So your trigger is what initiates respiration or inspiration, and your limit is what is achieved in your inspiration, and your cycle is what switches from inspiration to expiration. Okay, now coming to individual parameters. Trigger can be machine triggered and the patient triggered. So machine triggered means it is time triggered. So say if you set a respiratory rate of 12 breaths per minute, then after every 5 seconds, there will be a mandatory breath generated by the ventilator. This is called as the time triggered. Time trigger is always done by the ventilator and can never be a patient triggered one. Whereas flow and pressure triggered can be patient derived one. What is a pressure trigger? Maybe if you set the sensitivity, trigger sensitivity of minus 0.5 centimeter H2O to 2 centimeter H2O, the ventilator will sense any effort, negative airway pressure deflection from the patient as an initiation of breath. And this is called as the pressure trigger. Any negative airway pressure greater than this trigger sensitivity, that is minus 0.5 centimeter H2O to 2 centimeter H2O, will be sensed as the patient's effort, and the ventilator will deliver the breath. That is called as the pressure trigger. What is a flow trigger? Flow trigger is you give certain inspiratory flow and a return flow will be reduced. This is due to the effort generated by the patient. So this usually lies between 1 to 3 liters per minute, and the flow trigger sensitivity will be 1 to 3 liters per minute. So flow and pressure triggers are mainly patient triggered one, and time triggered one is usually a machine triggered one. Then limit. As you all know, volume control and pressure control ventilation, you can keep the limit to reduce barotrauma or volume trauma. There are certain modes have certain limits, and that can be achieved during your inspiration. Next comes your cycle. Cycle is what turns inspiration to expiration. So you have pressure cycles, which are the backups in your alarms. Then volume cycle, mainly seen in the volume control. And time cycle is pressure control one, and flow cycle is seen in the pressure support one. So this is the flow cycle. The importance of flow cycle is that it avoids the prolonged inhalation time, which is very important in your neonatal ventilation. Because when a preset flow is less than 25%, when the flow is less than the preset flow, that is less than 25% of the preset flow, then your flow cycling happens and the prolonged inspiratory time will be reduced. Next comes your breaths. There are 4 types of breaths: mandatory breaths, assisted breaths, spontaneous breaths, and supported breaths. What is mandatory breaths? Machine given breaths. So trigger and the breath is given by the ventilator. What are assisted breaths? Trigger will be by the patient and the breath will be by the ventilator. And what is spontaneous breaths? Both trigger and the breath will be from the patient. What are supported breath? So you will have a trigger in a supported breath which will have an inspiratory pressure greater than the baseline. So that is called as the supported breath. Same as the spontaneous breath, it will have a trigger, it will have a pressure greater than the inspiratory pressure. So that is from the baseline. So that is called as the supported breath. So here are the waveforms of the control or mandatory breath. You will never have a negative deflection. It is always a positive one. In assisted breath, you can see a negative deflection, which is a trigger. Usually, pressure triggers are between -0.5 to -2 centimeter H2, and this is the pressure trigger. And this is your ventilator breath. And in spontaneous respiration, you will have an inspiratory negative inspiratory breath and a positive expiratory recoil. Now, coming to the supported breath. How will the supported breath will be seen? So, I said the trigger will have a pressure greater than the baseline, inspiratory pressure greater than the baseline. So, this is depicted in the circle 1. Now, what are the conventional modes? Control manual ventilation. So, it can be further classified into volume control ventilation and the pressure control ventilation, assist control mandatory ventilation, intermittent mandatory ventilation. This can be further classified into synchronized intermittent mandatory ventilation and non-synchronized one, then pressure support ventilation and continuous positive airway pressure. Let's get detailed information about these. Okay, now, how is this mode going to act on your workout breathing? This mode acts as a fulcrum on the lever of the workout breathing. So you will it has to have a proper balance between the patient and the ventilator. When the workout breathing is increased, it will lead to, when the workout breathing is decreased, it will lead to atrophy on the patient side. And when the workout breathing is increased, it will lead to fatigue on the patient side. And on the ventilator side, what will happen? Let's see. So when the workout breathing of the ventilator is decreased, there will be hypoxemia or inadequate treatment. When the work of breathing on the ventilator is increased, then you will have ventilator-induced lung injury. So it is very essential to have a proper balance in the work of breathing between ventilator and the patient, which will be done only by choosing an appropriate mode. Now coming to the control mandatory ventilation. So in control mandatory ventilation, the hallmark point is that the breaths are all mandatory. No assisted breaths, no supported breaths, no spontaneous breaths. All the breaths are mandatory. And the trigger is time triggered. I already said time trigger is always from the mission. So you always set a rate, respiratory rate. For example, you say 12 breaths per minute. Then for every 5 seconds, there will be a mandatory breath generated. Then limit. According to the mode, whether if you choose volume control ventilation, the limit will be volume. And if you choose the pressure control ventilation, the limit will be the pressure. And cycle also the same. In volume control ventilation, your cycle will be your tidal volume. Whereas in pressure control ventilation, it will be the inspiratory time. So, what is the main disadvantage of this mode? Because this mode doesn't sense the patient's effort. It is very ideal only when the patient is sedated or completely paralyzed. That is, there should not be any effort from the patient side. So the patient requires complete sedation and paralysis, and he should not have any control over respiration. So the main complication will be your asynchrony and discomfort. It will be like pressurizing a person. So it will give the utmost discomfort and due to the patient ventilator asynchrony. So in this mode, that is in control mandatory ventilation, you always preset a tidal volume as in case of volume control ventilation, and preset pressure as in case of a pressure control ventilation. Then your respiratory rate will also be set and your inspiratory flow rate will also be set. In this mode of ventilation, patient can never breathe spontaneously. So he can never hyperventilate or never hypoventilate. Here the machine triggers and machine itself gives the breath, not assist. Machine itself gives the breath. So inspiratory valve open only with the patient's machine's effort. Whereas in other modes, patient's effort can also open the inspiratory valves. But in this mode, inspiratory valves are opened only by the machine's effort. Where are these modes used? Clay chest, near tetanus. In initial starting the ventilation, when the patient is working or fighting against the ventilator, you can use this mode. Then when the patient needs a respiratory rest or cardiac rest or neurological rest. Cardiac rest as in case of pulmonary hypertension and pulmonary edema, and neurological rest as in case of seizures or an increased intracranial tensions. So the main caution is ventilator dependence. Always keep that in mind that you need to prolonged ventilator controlled ventilation will lead to the dependence on the ventilator, which is due to the disuse atrophy of the diaphragmatic muscle fibers. And in this mode, no patient's effort will be sensed, which will mimic like choking. So will give the utmost discomfort and should be used with caution. Now, let's now distinguish between the volume control ventilation and the pressure control ventilation. So this is the equation of motion, as you all know. On the left hand side, you have your airway pressures. On your right hand side, you have your volume. So in volume control ventilation, you'll keep volume as a constant and the airway pressures usually changes. And in pressure control ventilation, pressures will be constant and your volume changes. So how does it act? When pressure changes, it directly acts on your resistance and your compliance. Whereas when the volume changes, it directly acts on the flow of the air to the patient. Next, coming to the parameters defined in the volume control and the pressure control ventilation. So in volume control ventilation, your tidal volume will be constant. Your peak inspiratory flow will be constant. And this is it. Whereas in pressure control ventilation, your peak inspiratory pressures will be constant and your plateau pressure will be constant. So coming to the compliance. So this is the formula for compliance. What is compliance? Is a change in unit volume due to the change in the unit pressure. So compliance is directly proportional to the volume and inversely proportional to the pressure. So when the compliance increases in volume control ventilation, your volume is always constant. So it acts on the pressure. So compliance is inversely proportional to your pressures. So when the compliance increases in volume control ventilation, airway pressure decreases. Whereas when the compliance decreases, the airway pressure increases. Okay. In pressure control ventilation, your pressure is kept constant. So the tidal volume is directly proportional to the compliance. So tidal volume increases with the compliance and the tidal volume decreases when there is a decrease in the compliance. Now coming to the intrinsic PEEP in both the types of ventilation. What is intrinsic PEEP? Where it is seen? So intrinsic PEEP is always seen in your COPD, chronic obstructive pulmonary disease. So there is an obstruction or an airway resistance. So in case of an airway resistance, you all know the airway pressure increases. Since the volume is controlled or constant, airway pressure increases. Whereas in pressure control ventilation, the pressure is constant. So in this case, the tidal volume decreases because chronic obstructive pulmonary disease is always an expiratory flow limitation series. So the tidal volume gets decreased. To trigger in both the any controlled ventilation, it is machine triggered. And the limit, it depends upon the mode. Volume control, the limit will be volume, and in pressure control, the limit will be the pressure. So cycle, tidal volume. Since it is a controlled ventilation, time cycling can also happen. In pressure control ventilation, it is time and flow. So the mode, as you know, volume control modes are VCV, KCVC, and your SIMV. And pressure control, PCV, PSV, CPAP, PEEP, all those things. So what are the factors that affect pressure during volume control ventilation? Patient lung condition naturally. Both the ventilation, the lung conditions play a major role. Then your inspiratory flow pattern, the set volume, what you said, and also the PEEP and the auto PEEP. In volume in pressure control ventilations that affect the volume during pressure control ventilations are the pressure gradient, the pressure you set, as usual, the patient's lung conditions, inspiratory time, and also the patient's effort. Coming to the scalar. What differences can you see in both the pressure control ventilation scalar and the volume control ventilation scalar? You plot time against flow, pressure, and volume. So, in pressure control ventilation, your pressures are constant. So, in the pressure time scalar, the inspiratory pattern will have a squared pattern. This is the set pressure control level. So, in volume control ventilation, your pressures are not constant. Here, the volume will be constant. So, the flow, inspiratory flow will be constant. See, this is depicted in the square. And your expiration is always a passive recoil, so it always comes below the baseline, both in the pressure control and the volume control. Now, coming to the flow time scalar in the pressure control ventilation. So, this type of scalar is called as a decelerating ramp. Why is it called so? Because you set a constant pressure and your volume increases. That is, the flow increases up to the set pressure and then starts decreasing once the set pressures are reached. And now, the expiration follows. The detailed explanation I will give you in the upcoming slides. So, this is how the flow time scalar is defined in your pressure control ventilation. Whereas your pressure time scalar, we can see the pressure time scalar in your volume control ventilation. It gives a lot of information. So this is an exponential curve. And this point is called as your peak inspiratory pressure. It always depends upon this pressure time scalar, gives information mostly on the compliance and the resistance of the system. So in volume control ventilation, you always set a tidal volume. So the pressures during inspiration rises, reach the peak inspiratory pressures at the set tidal volume. So when you achieve the tidal volume, the pressure is called as the peak inspiratory pressure. And after reaching the target tidal volume, your pressure drops and the expiration follows an exponential curve. So that is why the pressure time scalar looks like an exponential curve in your volume control ventilation. So coming to the volume time scalar, in pressure control ventilation, due to the pressures, it is an exponential curve. Whereas due to the volume, which is linearly in relationship with the inspiratory and the expiratory patterns, it is like a mountain shape. This is the conclusion between this. This is the differences between the scalars of the pressure control and the volume control ventilation. Now coming to your flow time scalar. See you have a constant flow pattern. So this is naturally a volume control ventilation. So here's the mechanical breath and this is the spontaneous breath. In spontaneous breath, you have a sinusoidal pattern due to the change in the inspiratory flow pattern according to the patient's level. Whereas since it is a volume control ventilation, you have a constant flow which is depicted as a squared pattern. This is the inspiratory curve. The expiratory curve follows the same passive recoiling in both spontaneous and mechanical breath. So the same shape is seen in both the things. Okay, this is how it is classified. So the maximum flow rate will be seen as the peak inspiratory flow rate and the expiratory flow rate is seen as your peak expiratory flow rate. So your total cycle time is from the start of one inspiration to the start of the next inspiration. So this is the total cycle time. The interval between the beginning of the first inspiration to the beginning of the next inspiration is called as the total cycle time. What is the inspiratory time? Beginning of the inspiration to beginning of expiration. And what is expiratory time? Beginning of expiration to the beginning of next inspiration. So this is how it is marked. Next, coming to your pressure time scalar. So this is also best seen in your volume control ventilation. So you can see your pressure marked on your y-axis and time on the x-axis. What is this gap? This is the baseline peak positive end airway pressure. Okay, at the expiration, this is your baseline peak. So here, this is your peak inspiratory pressures. So your pressure raises until the set tidal volume is reached, and then it drops down and the expiration follows. This is how the pressure time scalar is seen. But when you apply an inspiratory hold, you can differentiate between your transairway pressure and your transthoracic pressure can be measured. So this is the peak inspiratory pressure. When you apply an inspiratory hold, there will not be any airflow or resistance. So the pressure drops down suddenly and maintains a plateau. This is mainly due to the compliance of the alveoli. So this pressure difference is called as your driving pressure. So it maintains a plateau, and after some time, this pressure also falls and the expiration follows. So this part of the curve gives your transthoracic pressure, which mainly depicts your alveolar compliance, and this gives about information about your transairway pressure, that is resistance of your airway system. Now coming to the pressure control ventilation mode. So I have already said it is a decelerating flow pattern, right? How it is formed shall we see in detail, because this is your ventilator delivered pressures and this is your alveolar pressure. Before initiating a ventilation, the alveolar pressure seems to be 0 and the ventilator pressure is 20 centimeter H2. In the pressure control ventilation, your pressures are always constant. So the ventilator pressure, set pressure is always 20 centimeter H2. For each ventilation, your alveolar pressure gets increased. So first ventilation, it is 0 centimeter H2O, and in the second ventilation, you have 5 centimeter H2O, and in a subsequent breath, it is going to naturally increase. So there will be a pressure gradient. What is the pressure gradient? It is the difference between the ventilator pressures and your alveolar pressures. So in the first case, it is gradient is 20 centimeter H2 since the alveolar pressure is 0. So naturally, when the alveolar pressure increases, the gradient is going to decrease. So this is how it is seen on your scalar. See, initially the gradient is 20 centimeter H2O, and naturally, once the alveolar pressure starts increasing, your gradient is going to decrease. And finally, when the alveolar pressure equals the ventilator pressure, then you will have your expiration follows. That is, it will touch the baseline. This is how you can see the decelerating ramp pattern in your pressure control ventilation. Now, volume control ventilation, you can see about the advantages and the disadvantages. You always set a volume. So, no worries about your volume trauma. A stable, guaranteed tidal volume will be delivered. So, when tidal volume is stable, then the minute volume is always going to be stable. So, you will have a more control over the partial issues of the carbon dioxide. So, carbon dioxide level is going to be beneficial in your traumatic brain injury and your COPD. Since the flow rate is always less compared to the pressure control ventilation, your flow rate is always going to be less since it is fixed. So it is advantageous in bronchospasm. It can easily activate your pressure alarms. Then disadvantages is flow hunger, because you have a fixed flow which cannot meet up to the patient's demand. So this can result in flow hunger or flow starvation. What is barotrauma? In less complaint lung, it may lead to any injury due to the increased pressures. Increased pressures to attain the tidal volume. So it may result in barotrauma in less complaint lung. So in volume control ventilation, you can never think of recruitments. So there is poor recruitments due to low mean airway pressures and no leak compensation also. So this mode is ideally preferred in cases of resistance. So volume control ventilation is good for patients with increased airway resistance, whereas it's very harmful in patients with decreased alveolar compliance. Now coming to the pressure control ventilation advantages and the disadvantages. Due to the constant pressures, the alveoli will always remain open, so good recruitment. So lung protective ventilation, because the pressures are always limited, it's under your control. So it is a good effective tool, lung protective ventilatory tool. No barotrauma due to the low peak inspiratory pressures. No flow starvation, because initially the pressure rises, then only the decelerating ramp pattern will occur. So no flow hunger or no flow starvation. So this increases the comfort level of the patient. Then it also compensates for the leak, because when the leak increases, the pressures will naturally going to increase, which compensates for the leak. Then, your volume is going to increase according to the leak. So in a leak, there will be a drop in the pressure. So in order to keep the constant pressure, your volume is going to increase naturally. So the leak is compensated. So IU ratio can be manipulated, that is inverse ratio ventilation as seen in ARDS. Increased mean airway pressure, so better oxygenation. So this is a good mode for hypoxemia, type 1 respiratory failure. Whereas disadvantages are, you have a variable tidal volume, so volume trauma is more common in highly compliant lung. And also removal of carbon dioxide is not effective. So this is not a good mode for hypercapnic respiratory failure. So it is, the pressure control ventilations are good for hypoxemia but bad for hypercapnia. Now coming to your assist control ventilation. How is it different from your control ventilation? In control ventilation, you will have only mandatory breaths. Whereas in assist control ventilation, you will have assisted breaths in between the mandatory breaths. What is the difference between your mandatory breath and your assisted breath? I have already dealt it. In mandatory breaths, you will not have any triggers. But in assisted breaths, patient can trigger the breath, but the breath will be given by the ventilator. So you set a tidal volume of 500 ml. The trigger will be very minimal and the volume will be given by the ventilator. The 500 ml tidal volume will be reached for that patient. So let's see about the difference. So patient can trigger in your assist control mode, whereas in CMV mode, the patient can never trigger. And this can be used for active patients and also for passive patients. Not completely active, but partially active patients. Whereas in control mode, this mode is used only for passive patients only. So here is the graph. You can see you have a assisted breath. Here is a trigger and the ventilator is giving the breath. So this is an assisted breath. You have a time period. Within this time period, if there is no effort, then the ventilator gives a mandatory breath. Even when there is an assisted breath in between, also the ventilator will give the mandatory breath at the stipulated time. So this is how the assist control mode is going to work. So in assist control mode, the ventilator assists patient initiated breath. That means patient has triggered a breath, the trigger is sensed, and the ventilator will give the breath accordingly. The mandatory breaths can be either patient triggered or time triggered. That is mandatory mechanical breaths. Means that is trigger and the breath is given by the ventilator, which can either be assisted or time triggered. Now, how these mandatory breaths are going to change according to the respiratory rate. You set a respiratory rate, say 12 breaths per minute, but the patient can take more triggers. In that case, the mandatory breaths will automatically reduce depending upon the patient's respiratory rate. Whereas if your respiratory rate, the set respiratory rate is higher than the patient's respiratory rate, then your mandatory breaths are going to increase naturally. That is, when a patient is hypoventilating, mandatory breaths are going to increase naturally, and your spontaneous, your assisted breaths will be decreased. In a hyperventilating patient, your mandatory breaths are going to decrease naturally according to the patient's lung condition. So the breath can either be mandatory or assisted breath. Trigger can either be patient triggered or machine time triggered. Then cycle, volume or time cycle. Volume cycle as in case of volume assist control mode. Whereas time cycle as in case of pressure assist control mode. Limiting factor will be volume in volume assist control mode and pressure in case of pressure assist control mode. So here is what I said actually. So in each mandatory breath will also give a preset tidal volume. Say you set a tidal volume of 500 ml. The mandatory breath is also going to give the same tidal volume, and your assisted breath is also going to give the same tidal volume. That is, just a trigger will be sensed, but the breath will have the same tidal volume as set. Okay. The assist control mode, this is more important. The assist control mode does not allow the patient to take any spontaneous breath, but only senses the inspiratory effect. It senses the trigger, but never allows the patient to take a spontaneous breath. What is the difference between the spontaneous breath and the assisted breath? The spontaneous breath will have the tidal volume of the patient, whereas the assisted breath will have the tidal volume of the ventilator that we set. So if a breath is patient triggered, it is referred to as an assisted breath. If a breath is time triggered, it is referred to as a controlled breath. Now coming to the assist control pressure control mode and assist control volume control. So assist control ACBC mode is usually pressure targeted time cycle ventilation, whereas ACBC mode is a flow control volume cycle ventilation. How will you select between these modes? It is mainly depending upon the patient ventilator synchrony and also the lung protective ventilation strategies. Now coming to the graph. See, it's all same like this is volume targeted ventilation in an assisted mode. Everything is the same as in the control mode except for this trigger in the pressure train scalar. In both the pressure targeted and volume targeted ventilation, you can see here trigger. That is the difference between the assisted mode and your control mode. Yeah, all of the things will be the same. Now coming to the parameters, the trigger can be patient or time triggered. The limit can be flow or inspirated pressure depending upon your volume or pressure control. Cycle, volume, cycle in case of volume control, time cycle, inspirated time cycle in case of your pressure control. Then gas flow, it is very important. It is constant in volume control ventilation. Since flow is always constant in a controlled ventilation, volume control ventilation, but it is decelerating in a pressure control ventilation. Next, it is your pressure curves. It is exponential as in case of volume control ventilation. It is going to be constant as in case of pressure control ventilation. Now, coming to the indications, advantages, disadvantages of your assist control ventilation. What's the indications? So, in the control ventilation, you require sedation and paralysis. Whereas in this patient, you can have your respiratory drive. It is very, very important for the respiratory drive to cause a trigger. So awake patients, sedated patients, all these patients, stable respiratory drive can be put on the assist control ventilation. It strengthens your respiratory muscle and also it initiates. For initiating weaning, you can use assist control ventilation. So the primer mode is your controlled ventilation. That is the starting mode. To initiate weaning, you can just switch on into the assist control ventilation. Advantages, it reduces naturally, it is going to reduce your work of breathing. Patient ventilator synchrony is better compared to the controlled ventilation. Less ventilation perfusion mismatch. So diaphragmatic muscle fibers will be strengthened in this mode. So normal PaCO2 by maintaining your respiratory rate will be maintained. Whereas the disadvantages will be auto beat or dynamic hyperinflation, which may lead to your barotrauma. Then breath stacking is more common in this mode. What is breath stacking or trouble triggering? It is the superimposition of the mandatory breaths over the spontaneous breaths, assisted breaths. In case of assist control ventilation, your assisted breaths may superimpose over your mandatory breaths, which can be seen as a double trigger of breath stacking. So annular hyperventilation can result, which may lead to respiratory alkalosis. Now coming to your intermittent mandatory ventilation. Intermittent mandatory ventilation is nothing but your controlled mandatory ventilation with spontaneous ventilations in between. So you have your mandatory breaths with your spontaneous breaths in between. So these spontaneous breaths are usually seen during the expiratory phase of your mandatory ventilator breaths. So you have a series of breaths. Mandatory breath, you will have mandatory breaths and your spontaneous breaths. That is, will be in a series. But the ventilator will sense the patient's effort and schedule mandatory breaths accordingly. When there is more spontaneous breath, then the ventilator will reschedule the mandatory breaths. So the ventilator will deliver a preset number of time cycle mandatory breaths and allows the patient to take in a spontaneous breath with the tidal volume of the patient. Whereas in your assisted mode, the tidal volume will be set by the ventilator. In your intermittent mandatory ventilation, this tidal volume is the tidal volume of the patient. So here also the breath can either be mandatory or spontaneous, whereas in assist control mode, it is mandatory or assisted. Trigger, it can either be patient triggered or time triggered. Limit, it is usually volume. Usually volume, depending upon the mode you set. In pressure targeted ventilation of synchronized SIMV, you can see the pressure as the limiting factor. And also your cycle. Cycle is usually volume. Then see, in intermittent mandatory ventilation, you have a mandatory breath. These are the mandatory breaths. And you have a spontaneous breath in between of patient's tidal volume. Okay, it's not the ventilator's tidal volume is here, but the patient's tidal volume is here. So this is with the intermittent mandatory ventilation. How it is different from access control and SIMV. So intermittent mandatory ventilation can further be classified into SIMV and non-SIMV. Non-synchronized means it is not synchronized with the spontaneous efforts are not synchronized with the mandatory breaths. Whereas synchronized intermittent mandatory ventilation, these are synchronized. How is it going to be synchronized? We'll see in the next one. So how is it going to act? That is the demand valve. Demand valve is nothing but a valve which allows a continuous flow of gas during mandatory breaths. So during mandatory breaths, if a patient is triggering or if there is an inspiratory effort, then the flow of gases will be turned out into a spontaneous breath. So patient can be so the spontaneous breaths are always synchronized with the mandatory breaths. How is it different from the assisted control ventilation? This is how the intermittent mandatory ventilation is different from the SIMV. Synchronization, non-synchronization. Non-synchronized means the demand valve will be closed so that there is no continuous flow of gases during your mandatory breaths. Whereas in SIMV, the demand valve will be open so that there will be continuous flow of gases, which will sense the patient's trigger, and the spontaneous breath will be turned out into a mandatory breath by synchronizing it. So there is a synchronization window, which we'll discuss later. So now how we can differentiate intermittent mandatory ventilation from your access control ventilation. So in access control ventilation, every inspiratory effort triggers a ventilator inflation. As I said, the trigger will be from the patient, the breath will be from the ventilator. Whereas in IMV, the trigger from the patient and also the breath is also from the patient. That is the tidal volume will be of the patient's tidal volume and not the ventilator's tidal volume. That is the difference between the SIMV and intermittent mandatory ventilation and your access control mode. Now, intermittent mandatory ventilation is outdated because of the non-synchronization. Now it is replaced by SIMV. So previously it was used for weaning, but now it is replaced by synchronized intermittent mandatory ventilation. Intermittent mandatory ventilation is nothing but CMV, which allows spontaneous breaths in between. That is in nutshell. Now, what are the advantages of intermittent mandatory ventilation? So it facilitates weaning. It facilitates transition from full ventilator support to partial ventilatory support. Facilitates weaning. Naturally strengthens your respiratory muscles. Reduces ventilator perfusion mismatch. And reduce mean airway pressure. Any mode of weaning you have to fulfill these requirements. So disadvantages, as I said, there will be superimposition of the spontaneous breaths over the mandatory breaths, which can result in breath stacking, double triggering, which can lead to dynamic hyperventilation or also water. And asynchrony is one more complication, but this can be met out by synchronizing in your SIMV mode. Then due to asynchrony, there will be increased work of breathing. And there is an increased work of breathing will naturally lead to ventilator-induced lung injury, paratrauma, and volume trauma. Now, synchronized intermittent mandatory ventilation. It is nothing but the intermittent mandatory ventilation with the synchronization of the spontaneous breath with the mandatory breath. So, your assisted breaths to the patient at the beginning of the spontaneous breath, time-triggered mandatory breaths. So, here the breath stacking is avoided since due to the synchronization. So, what is synchronization window? It is just a time interval just prior to the prime triggering. Where is time triggering take place? It is just before the mandatory breath. So when this is called the synchronization window. When there is an effort in such a period, then this will be turned into a mandatory breath. That is the importance of the synchronization window. So synchronized window is nothing but the time interval just prior to your time triggering. Time triggering is always seen in your mandatory breath, before mandatory breath. So when an effort is sensed during this period, this will be turned into a mandatory breath. That is the importance of a SAMV mode. What is SAMV rate? You have spontaneous breaths and mandatory breaths. But in SAMV mode, the rate is usually the set mandatory breath rate. The SAMV rate is usually the mandatory breaths, number of the mandatory breaths, not the number of the spontaneous breaths. Okay, see, these are the scalars in volume targeted ventilation and the pressure targeted ventilations of the SAMV mode. So the name itself suggests it's volume targeted. So your volume is constant. So the flow will have a square pattern, pressure will have an exponential curve, and volume will have a mountain slope appearance. But in SAMV, you will have a spontaneous breath in between your mandatory breaths. So the mandatory breaths only will follow the volume targeted scalar, whereas the spontaneous breaths are usually following the normal scalars of your inspiration and expiration. Okay. In pressure targeted ventilation, your flow is decelerating pattern and your pressure has a constant inspiratory pattern with a trigger and your volume is an exponential curve. But the spontaneous breaths will have the patient's tidal volume, patient's normal spontaneous inspiration and expiration. This is all. It is seen. Your normal inspiration will have a pressure time scalar, will have a negative deflection and a positive expiration. So the same spontaneous respirations will be seen in between, but the scalars will be different as in case of a pressure targeted and your volume targeted ventilation. So breaths can either be mandatory breaths or spontaneous breaths. Trigger, time trigger, that is mission triggered or patient triggered. Cycle volume or time triggered, time cycle, or flow or pressure according to the mode set. Now coming to the advantages and disadvantages of your SAMV mode. The same muscle strength is increased, ventilation perfusion mismatch is compensated, decreased mean airway pressure, facilitates patient comfort due to the synchronization. What are the main disadvantages? Main disadvantages is your enthusiasm to wean the patient very soon. So when you try to wean the patient very fast, it may result in an increase of the work of breathing, which may lead to your muscle fatigue and ultimately will lead to weaning failure. How can you overcome this? You can overcome this by either increasing your mandatory breath rate. So in synchronized intermittent ventilation, you will have spontaneous breath rates and the mandatory breath rate, and your SAMV rate is always your mandatory breath rate. So you can always reduce the mandatory breath rates, breath frequency, and watch for the signs of fatigue. If there are any signs of fatigue, then you can increase the mandatory breath. Hence, you can overcome the weaning failure. Otherwise, you can combine it with the pressure support ventilation. What is the effect of pressure support on your SAMV mode? When you use in combination, these spontaneous breaths which we take will have a pressure support. So this will meet out the patient's requirement. So limited tidal volume will be met out by the pressure support you give. So it will facilitate weaning. So the disadvantage is mainly the attempt to wean earlier. Always watch for signs of fatigue, and also using in conjunction with the pressure support ventilation can facilitate easier weaning. Now coming to your pressure support ventilation. So throughout these things, you have seen spontaneous breaths, mandatory breaths, and assisted breaths, but no spontaneous breaths alone. But in this ventilation, you can see only spontaneous breathing. This can be applied only to the spontaneously breathing patient. So here the inspiratory effort will be augmented by the ventilator. It is not assisted or not synchronized. It is augmented by the ventilator to the set level of your inspiratory pressure. So the breath is spontaneous, the trigger is patient triggered, and the limit is pressure limiter. Cycle is flow cycle. So this the flow cycling. This is the hallmark thing which makes its place in your neonatal ventilation. Pressure support ventilation is mainly seen here for your neonates because What is flow cycling? Actually, when the flow gets reduced to the preset 25 gets reduced to 25% of the preset flow, then your flow cycling happens. This avoids the prolonged inflation time. So this is how it is going to help in your neonatal ventilation. Now, it is usually a combo mode. Flow pattern is your decelerating ramp pattern, and it is a combo mode. So when it is used in conjunction with pressure support, it facilitates weaning. When it's used in conjunction with PEEP, PEEP is not a standalone mode. It's always used in conjunction. So PS plus PEEP will prevent atelectasis. Okay, how will you set your pressure support? Initial setting will be based on the pressure support level. The level should be PIP minus P plateau. Peak inspiratory minus P plateau will be your pressure support level that has to be kept initially. Now, how PSV, CPAP, and PEEP are different. In pressure support ventilation, there is a positive airway pressure at the beginning of your inspiration, whereas in CPAP, it is throughout the respiration. That is, positive airway pressure is seen during inspiration and also during expiration. In PEEP, positive airway pressure is seen at the end of expiration. Now, coming to your SIMV mode. So we can see the difference between the SIMV, pressure support ventilation, and the CPAP. See here, you have a mandatory breath, in between which is your spontaneous breath in your SIMV mode. Whereas this is a pressure supported ventilation where you have a decelerating ramp pattern, flow cycling happens, and the trigger is also present. This is the pressure support level. When you say 25 centimeter H flow, this will be the pressure support level in your pressure support ventilation. This is how it is going to happen. In CPAP, it is always seen in your spontaneous breathing patients, so sinusoidal pattern. And in pressure time scalar, you will have a continuous airway pressure throughout the respiration. That is during inspiration and also during expiration. So this is a constant pressure level you always set by 10 centimeter, and this will be the CPAP level you set. Okay. Now coming to the combo modes. SIMV plus PS, CPAP plus pressure support, and SIMV plus pressure support plus CPAP. See? What I said in SIMV mode, you will have a mandatory breath between which you have a spontaneous breath. In combination mode, these spontaneous breaths will be pressure supported. That is the difference between your SIMV mode and your SIMV plus pressure support ventilation. So you have a mandatory breath in between which you have a spontaneous breath which is pressure supported. Here, this is the patient's tidal volume, spontaneous breath of the patient's tidal volume, which doesn't get pressure support. But here it is pressure supported, so that it always recruit the alveoli. The recruitment of the alveoli is better in this mode, so it facilitates weaning. Now coming to CPAP plus PSV. So CPAP, this is the set level of the CPAP and also the pressure support level. This is the pressure support level. So you'll have the scalar of the pressure supported ventilation with the continuous positive airway pressure in your pressure time scalar throughout the respiration. This is the difference between your CPAP pressure support low mode and your combination mode. Now SIMV plus pressure support plus CPAP. So in SIMV mode, you have mandatory breaths with your pressure supported breaths in between and a continuous positive airway pressure throughout the respiration. That is during inspiration and also during expiration. This is the difference between these modes used in combination. Now coming to the advantages and disadvantages of your SIMV your pressure support ventilation. Okay, I told that the SIMV modes and pressure support modes are weaning modes. But how will you facilitate weaning in these modes? In SIMV mode, I said the SIMV rate is the mandatory breath rate. You decrease the mandatory breath rate and you watch for signs of fatigue and then you wean the patient. Whereas in the pressure support ventilation, you decrease the pressure support. Say the initial pressure support is 15 centimeter, you always decrease the pressure support and you watch for signs of tachycardia, tachypnea, and then you wean the patient. This is how the weaning is affected in both the mode. Now, advantages. Pressure support ventilation, you will have an increased patient comfort. The ventilatory workload is minimized. It finds its place in your neonatal ventilation, that is due to the flow cycling. It is an efficient weaning. Now, disadvantages, it is not suited for patients with no respiratory drive. So, ventilatory drive is very much important because this mode is only for spontaneously breathing patients. So, ventilatory drive is the essential part of this mode. So, it's not suitable for patients with central apnea or hyperventilation. So, high airway pressure patients also can lead to hemodynamic disturbances in patients with high airway pressures. So, this mode is not advocated in this kind of patients. So, hypoventilation can result and auto triggering can also happen in this mode. So, we will see advantages of each mode individually. So, in access control ventilation, compared to control ventilation and SAMV, you will have a better comfort level of synchronization. So, there will be reduced work of breathing. Whereas in pressure support ventilation, patient comfort will be very increased and the patient ventilator interaction is also increased. The synchronized increased. In SAMV, cardiovascular functions are met out. So in assist control ventilation, volume and pressure, tidal volume is set and peak inspiratory pressures are limited. In pressure control ventilation, peak inspiratory pressures are limited, so no barotrauma. In assist control volume ventilation, tidal volume is set, so no volume trauma. Now coming to the disadvantages of each mode. In assist control ventilation, so hemodynamic effects are the main thing and may lead to hyperventilation. Alveolar hyperventilation is the main disadvantage of this mode, which may lead to respiratory alkalosis. In assist control volume ventilation, inspiratory pressures can lead to barotrauma. In pressure control ventilation, it may lead to volume trauma or inadequate volume, which may lead to collapse. Now coming to the pressure support ventilation. So in this an alarm, usually a flow cycle, when it pressure cycle only, the apnea alarm will sound. So it is only a backup. And this pressure support ventilation is not ideal for all patients. It depends upon the patient's tolerance to the changing pressures. So this mode cannot be set in for all patients. Now SAMV mode, increased work of breathing compared to the assist control ventilation. Otherwise, it's a good mode. But work of breathing can increase because the spontaneous breaths can never be spontaneous breaths are of very less tidal volume, which cannot meet out the patient's requirements. So the work of breathing can be increased compared to the assist control mode. Now individual waveforms of each mode. So spontaneous ventilation, you have a negative inspiration, the positive expiration on the baseline, depending upon the baseline. Whereas in a spontaneous ventilation with the CPAP, see, this is the CPAP level you set. You have a spontaneously breathing patient with a normal negative inspiratory curve and a positive expiratory curve with the set CPAP level. Now coming to your assist control ventilation. Assist control ventilation, you have a trigger and followed by a ventilator given breath. The tidal volume is what you set. That is your assist control ventilation. Whereas in assist control ventilation with PEEP, have a trigger ventilator breath with an added PEEP. Now coming to your pressure support ventilation, this is your set pressure support level. So say 20 centimeter H2O. So this is seen in your spontaneously breathing patient. So this is the waveform in your pressure support ventilation. In SAMV mode, you will have a mandatory breath in between which there will be spontaneous breaths of the patient's tidal volume. So these are the mandatory breaths of ventilator's tidal volume, set tidal volume. And this is the in between the mandatory breaths or the spontaneous breaths with the tidal volume of the patient. Now, SAMV mode with pressure support ventilation. So this spontaneous breath of the tidal volume will be replaced by the pressure supported breath in case of this combination mode. SAMV mode, mandatory breaths, supported breath, and then the mandatory breath. Mandatory breaths are in between supported by the pressure support ventilation. Now coming to your controlled mechanical ventilation, there is no trigger. Only ventilator given tidal volume, ventilator breaths are seen at the set respiratory rate. These are the differences between the all the waveforms in your different modes. Now coming to CPAP, for conclusion's sake, CPAP is an ideal mode for non-invasive ventilation, but it also finds its place in invasive ventilation as a tool of weaning. So it is just a supportive mode for a spontaneously breathing patient with oxygen at a constant low pressure, say 5 centimeter H2O. It is just to maintain your airway patency. So it helps in recruiting your alveoli, increases the functional FRC, increases the oxygenation, and also decreases the work of breathing. Indications: congestive heart failure, COPD, obstructive sleep apnea, or obesity hyperventilation syndrome. In immunocompromised patients, it is an ideal mode for weaning in all the patients with neuromuscular diseases and neonatal ventilation. Contraindication: cardiac or respiratory arrest. This mode can never be used. And the patients who are arrhythmic or having hemodynamic instability can never have this mode. Then it is contraindicated in severe encephalopathy and also in upper airway obstruction. How is it different from BiPAP? CPAP. In CPAP, you set a single pressure throughout inspiration and expiration, whereas in BiPAP, you will have a high inspiratory positive airway pressure during inspiration and a low expiratory positive airway pressure during expiration. That is respectively called as IPAP and EPAP. So let me show you the waveform of your continuous positive airway pressure ventilation. So CPAP is usually seen in a spontaneously breathing patient. It is actually a PEEP applied to the spontaneously breathing patient, and the breaths are always spontaneous. So this PEEP is a conjunction mode and it is not a standalone mode. Additional inspiratory support will the standalone mode. That is how. So that is to do with your ventilator, right? Hope I think I have gone through this journey as far as I know. So thank you. Have a safe journey, ventilation journey. So it's all in your hands. So drive safely. Thank you.